and welcome back to our webinar series, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. In today's webinar, we are looking forward to discussing practices to support resilience for long-term care providers. I will be moderating this session today from my home office in Ottawa, Ontario. I would like to acknowledge that my office in Ottawa is on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. From this territory, we are pleased to offer today's webinar with French simultaneous interpretation. If you wish to listen to the session in French, then please select French from the interpretation menu at the bottom of your screen. We invite you to use either French or English when entering your questions and comments in the chat box. Also would like to remind everyone that this session will be recorded and a summary will be made available to review or share with colleagues who have missed today's session. So as a reminder, the Long-Term Care Plus program and webinar series are based on the Reimagining Care for Older Adults report that was published in July 2020. The report focuses on promising practices in 6 key areas that have the potential to reduce the risks of future COVID-19 outbreaks or mitigate their effects. And speaking of reports, we are pleased to say that we've just released a new report from Dr. Carol Ester and the TREC team from University of Alberta. This report focuses on LTC provider resilience through the COVID-19 pandemic and is the topic of our webinar today. You can read the full report from our website under LTC Plus Resources and Promising Practices. We have also released a report with the Nova Scotia Centre on Aging focused on supporting in-person family presence and communication with families in long-term care. That report was featured on last week's webinar, and we'll put a link to both these reports in the chat throughout today's session. As always, we're pleased to offer this program in partnership with many different partners from across the country, including BC Patient Safety Quality Council, New Brunswick Association of Nursing Homes, CADITH, and CMA Foundation. So now it is my pleasure to introduce our speaker for today, Dr. Carol Ester. She is a health services researcher and holds a Canada Research Chair in Knowledge Translation in the care of older adults in long-term care settings. She is Scientific Director of the Pan-Canadian Longitudinal Research Program, Translating Research in Elder Care, also known as TREC. She's been the recipient of several awards and distinctions, among them the Order of Canada and the Betty Havens Prize for Knowledge Translation in Aging. She is a fellow in the Royal Society of Canada, the Canadian Academy of Health Sciences, the American Academy of Nurses, and the Canadian Academy of Nurses. So over to you, Carol.
Terrific. Thank you very much, Tanya. And so pleased to be here today and welcome everybody. I see there's a large group in the audience. I can't tell you how disturbing it is, and it hasn't gotten any better to present to a large group and have no idea what the reaction is from the audience. But I'll be glad when we can once again present and talk and have discussions in person. Not that I'm expecting that anytime immediately. So I'm going to talk today just at a very high level about the report that HEC commissioned us to do. And before I start, I want to thank Dawn McLeod, Christina Weiss, and Sandra Young, who helped and did the heavy lifting on this report. And without it, we wouldn't be here. So let's do the next slide. Great. So I'll talk a little bit, very briefly, about the impact just based on a study we're nearly through collecting data on, how we did it, what we did, and a few observations at the end in terms of what it looks like early signs of promising practices are shaping up to be. Next slide. These are just a few super high-level observations. We were commissioned by Alberta Health to do a study on the impact of COVID, and we're doing it in collaboration with Manitoba and Nova Scotia. And it had several pieces to it, a qualitative piece early in the year, and we're just now about to take out a large survey looking at the impact of COVID on long-term care staff. It's particularly timely for us to have just taken a large wave of data out of the field about 2 weeks before the sector was closed because of COVID. So we have a nice baseline with which to compare. But just a few observations from the qualitative study, and this will not be news to anybody, but it goes to some of the promising practices that people are talking about. The level of distress among staff caused by resident distress is probably the number one impact that we heard in our qualitative work. This was extraordinarily difficult, not only on the residents and families, but on especially the frontline staff. The one worksite policy out here at least was a double-edged sword. It had some advantages, but it also resulted for some people in reduced income. If you asked a question, and this is not to trivialize it, this is actually the right answer. The answer was workload and staffing. And I say it was almost always the right answer because it permeated through the entire system, whether that was caused by supply shortages or people unavailable or one worksite policies or loss of your casual and temp pools. The workload and staffing issue was there before COVID and was exacerbated in the extreme, as you all know, during COVID. Communication was a major theme in terms of impact. Good communication made it easier and poor communication made it harder. And consultation or lack thereof sometimes with frontline staff could either be a problem or a real advantage. The mental health impact on the frontline staff, and by frontline, I mean managers, regulated, and the unregulated workforce was significant. We're trying to quantify that a bit now in the survey, but we haven't got that part of the study quite finished. But people talked in all kinds of different ways about the high toll, emotional and mental toll that it took. But there was also a fair bit of resilience in the system. And a lot of that came from the teamwork that people were able to strengthen and the support they got from peers and sometimes, as we'll talk about, from managers. So those are just high-level insights from interviews that we did, and we're trying to refine that now and quantify some of it. Those observations of impact go directly to some of the promising practice that people have identified. So let's look at the next slide. So this was our goal, and I won't belabor it. Let's move right on to the next slide. So what we did was we did semi-structured interviews with 13 leaders in long-term care across 7 provinces and territories, and 7 researchers and 5 knowledge brokers in 3 provinces. Of note, we had about 17 researchers who didn't talk to us because they said their work was not really, didn't really relate to what we were asking about. That is significant finding because I think it heralds or suggests that we have a pre-existing lack of adequate numbers of researchers, both doing relevant work, applied work in long-term care, but also doing work focused on interventions and evaluating them, or innovations and evaluating them. So it's just a piece that we saw as we tried to contact people for interviews. Next slide. So I'll talk first about what we heard from the leaders. Next slide. And if you go to the report online, you'll get much more detail about who the actual leaders were and in which exact homes, if that's important to you. My assessment, based on everything I've read and the interviews we've done here and in other studies and the people I've talked to, is that the people we did interview were not at all atypical of people in the long-term care sector in general. So I feel reasonably confident about the findings that we have here. So the first theme, and a very big theme, maybe the dominant theme, was visible leadership. You can see here a couple of quotes from people in the sector showing up continually in scrubs to work on the floor. And we were always visible and accessible. We ensured we had 24-hour on-call support for all shifts and on every weekend with leaders in the building. That was not necessarily the typical response across the sector, but when this kind of support happened, we heard from the front line in other contexts that it was absolutely critical. So I would say that it's reasonable to say that frontline staff separated leaders into two broad groups, those who were visible and those who were less visible. And there are lots of reasons why people aren't visible, but regardless, that showing up and rolling up your sleeves and being there for the staff, it wasn't so much that the leaders or managers always did things that were rocket science, but it was about working shoulder to shoulder and being part of the effort. It was part of the front line feeling acknowledged and that they weren't alone and that they were valued. That has come through in multiple interviews that we did for this and elsewhere. Showing up on weekends and evening shifts. Now, I say that as if it was easy to do. We have some other evidence in other studies that the managers, primarily the care managers, but also the DOCs and administrators, may have, in fact, have taken one of the biggest hits in terms of the impact on their mental health. So they have, as you all know, they're squeezed between the top people they report to and the people who report to them and families and community and everybody else from the side. So they're in a tremendously difficult position, but for those who could be there, it was incredibly important. Frequent, layered, and transparent communication with all kinds of strategies also came out loud and clear. And I think I have it on another slide, but small meetings, touching base, huddles, start of shift, end of shift, checking in, all those personal things that helped the staff feel like they were seen and heard and understood were dominated as one of the most important things that needed to happen. Some places, as we'll see, had more formal strategies around leadership and how they could support. Next slide. So this was a little model that came from the Yukon. They had this in place pre-pandemic and really dusted it off and built it up during the pandemic. And it's straightforward things. Being there, being generous with information and feedback, being genuine and curious, being calm and wise, always easier to say than do, and delegating appropriately and intentionally. One of the things that we didn't see, because we didn't really ask about it here, but that we've seen elsewhere, is that everybody in the entire sector worked beyond their scope. And often that was an incredible help for the homes that were doing this, which was most of them. And often it brought additional satisfaction to the people who were doing different things. This is my movie cat, who never shows up unless I'm on a Zoom. But sometimes that out of scope and working outside your role and doing other things it was a double-edged sword, because sometimes some groups perceived that they got the grunt work or the harder work or the more mundane work, and some of the people who weren't normally less visible were able to do some of the things that they valued a lot. And often that was around family support and the emotional and social support for residents. Next slide. Team effectiveness was another really big theme. Creating what you might call a climate of cultural and psychological safety. So regular check-in conversations. Instead of thinking about things in terms of disciplinary or remedial processes, replacing them with an attitude and a practice of opportunity. What can we learn here? What can we do different? How can we make it better? Support for grief. There were a lot of disrupted grief rituals and practices, as you know. So there's I suspect, a collective, as well as thousands of individual, not well processed grief processes in the long-term care sector. Embracing diversity and cultural differences and inclusion and competence, and providing care aides with a sense of control over aspects of their work, which is sometimes very hard to do. But the care aides, personal support workers, personal attendants often feel like they don't have a sense of control. Most of the leaders talk to us about moving away from a traditional hierarchical approach to different sorts of reporting structures. encouraging staff to speak up. And these debriefing and peer-to-peer support sessions around grief and loss were a common theme and really seemed to be quite important. There was sometimes, however, a reluctance for the frontline unregulated staff, PSWs or carries, to be engaged in some of these groups. And certainly there was a significant reluctance for them to be engaged in what sound to us in this study and in others like generally, I don't want to say questionable, but generally, most places have an employee assistance program, and they weren't generally perceived as the first go-to. They were often seen as ineffective or not what I want to do. The frontline staff turned often to their faith, to their families, to their team, and to other groups to get a sense of connection and support. I think that implies that not necessarily that we should get rid of employee assistance programs, but maybe rethink how they're constructed, especially in the wake of the pandemic. I talked about the full scope of practice. So many leaders try to embrace and let the full scope happen, but some groups have more room to expand their scope and others have less room. So we heard quite a bit here and elsewhere about the, and it's all related to short staffing. The frontline staff and the care aides and PSWs certainly for the most part, but also the LPNs and RNs were so busy meeting essential fundamental needs. So for those of you who were schooled in Maslow's hierarchy, the basic safety and physiological needs of hydration and feeding and trying to help people with hygiene, that they couldn't really move much beyond that scope. And what they needed was help with doing those essential services. And sometimes, not always, they perceived that there were others help with other things, but not necessarily those. Next slide, please. Well, this was really important recognition. This was a site where they had asked families for input, and they got a really massive response. And they came as notes and stories and poems, and had a major impact on the staff in terms of feeling valued and appreciated. The not feeling valued and appreciated is, for any of us at any given time, difficult. But for this group of the frontline staff during a pandemic, when the work conditions were sometimes almost intolerable, was especially important. So this is one creative way that one home had approached it. They published these submissions as gifts for the staff, by the way. Next slide. There were all kinds of different things people did educationally. So we all know about education, and it's often the first thing, it's our go-to when we don't know what to do. But this wasn't traditional education. People tried all sorts of different things. Tabletop simulations to try and figure out what to do when and if. Contracting short-term subject matter experts in mental and emotional health and support to do short, just-in-time, brief episodes of training around mental health and grief and loss and burnout and resilience. One New Brunswick group talked about the value of a dedicated educator offering these just-in-time learnings and integrating that into the workflow. Many sites talked about the increasing the frequency of their huddles, and a few highlighted opportunities for all staff to lead huddles, including the care aides or PSWs. They were not just about giving and sharing information in these huddles, but it was also a forum for staff input into decisions. That bi-directional exchange is really, really important. Now, some sites have gone back to more didactic staff meetings, but I think there may be an opportunity to say, well, which ones of these kind of emergency procedures that we put in place that we ought to keep? Some leadership teams instituted mandatory education for anyone in a supervisory role. to prepare them how to recognize how people show up at work when they are well and how they show up when they're not well, and what the key indicators are for staff under extreme stress. That particular program, which is from the Yukon, also provides supervisors with strategies to support staff and some information about how to refer staff to other resources. They'd already started this pre-pandemic, but they ramped it up during the pandemic. So that's an important little comment. Those who had something kind of idling, even if it wasn't fully formed pre-pandemic, seemed to be able to mobilize that more quickly. When you start from a straight stop, it's harder, as we all know, in whatever we do. Next slide, please. Many of the sites talked about wellness programs. Some had them and were able to mobilize them further, and others had to initiate them. There was a home in Nova Scotia that talked about building an on-site home gym with personalized training. And they had a big focus on physical health and health challenges. And they had a really high percentage of their staff participating in this program. And it served not just to help people with activity and physical health, but as a bonding activity. They also engaged their residents in a program, a mobility program, to walk across Canada. As you know, there are a lot of apps out there now about, walking the Cabot Trail, walking the Canada Trail, et cetera, et cetera. Several leaders underlined again this renewed attention on fostering provider mental health. A leadership group in BC funded nursing leadership courses through Safe Care BC, focusing on workplace health and safety. They found collaborative skills that the leaders gained helped give the care aides and PSWs a voice. Some leadership teams did refer people to informal EAP programs, to social workers, to spiritual care providers, coaches, or external consultants. One team in Alberta found that it was more effective and staff were more responsive when internal people were convening debriefing sessions rather than bringing in external folks. We certainly heard that from the frontline care aides and PSWs, that they were sometimes leery of professionalized or what they might have perceived to be external, over-professionalized assistance, and look for other areas. Next slide. So when we talked to the researchers, the information wasn't as rich, just because there weren't as many researchers that we found that had the sorts of things happening that might help. But here are three. Bonnie Lashewicz in Calgary is looking at mental health support to prevent moral and help with moral injury. She's working on an electronic toolkit. There's a researcher at UBC looking at a scheduling tool. And Sienna Casper in Lethbridge is working, and has been for some time, on this feasible sustainable culture change initiative, which is really about training and empowering care aides to drive improvement in care processes. And that's not dissimilar to some of the work that our group has been engaged in. Generally, and certainly from Sienna, there's a sense and findings that support that when staff are engaged in influencing change, rather than feeling like change is happening to them, that they're more creative and productive. That's easy to say. It's more challenging to actually do that in practice in a way that's really substantive and lasts. Next slide. We're leading several initiatives. The one that's most germane to COVID is that we're looking at a very, well, it doesn't feel very small. It's quite large, but a modest innovation to try and see if we can offer and help care aides and nurses sustain a self-help practice around managing stress in the immediate situation. And it's got a little educational component, and it teaches a particular breathing technique. And we're going to see if we can demonstrate. We know that there's lots of evidence that it works, but can we demonstrate how it works and that it works in this population, trying to do it with their particular incredibly complex lives and work schedules? So most of the things that have been tested by us and others, they will work in researchers are infamous for doing them in populations that are not particularly always relevant to areas like long-term care. So there's a fair bit of work done with physicians, and that's important work. But relatively speaking, there are few physicians in long-term care relative to, care aides and nurses and allies and others. Sometimes, but not always, professional nurses are studied, but when they are studied, they're often done in hospital settings. And so that's a very different, as you well know, setting. We also have done a couple of trials, more rigorous tests of supporting managers to improve performance and to support and empower care aides or PSWs to lead improvement interventions. And I'll talk later, if there's time, about why that might have anything to do with COVID and what happens to staff at that point. Next slide. Ontario's got a TLC for LTC. I thought that was a very clever use of acronyms program it's an appreciative program to thank them for their efforts. Another group has adopted the national standard of Canada's standard on psychological health and safety. Well, not another group, it's being adopted across Ontario. Mindfulness-based stress reduction programs have popped up in a number of places. Reflection rooms, which are spaces designated to encourage acknowledging and talking about death and grief-related rituals, and to honor spiritual practice and support transitions. That's one that where they're being used seems to be particularly well received. Next slide. So I raced through this pretty quickly, but if I had to make summary observations based on our look at the literature when we were early on, and a quick look recently, and the conversations that leaders in nursing homes had with us and researchers had, was that active, accessible, and authentic leadership combined with participative decision-making was absolutely key and fundamental. That a lens towards continuously improving and learning, and looking at it as learning and not in any way punitive, modifying these traditional hierarchical structures that we have into more just and trusting would be one way to say it. Organizational cultures. I mean, people talk about organizational culture in different ways, and there's a lot of components to it. And greater and meaningful participation about care leads to a sense of meaning and purpose, and subsequently improved experience for the residents. It would be hard to overstate how important, even in the most beleaguered sites, it's been when they felt they were part of decision making. And that goes directly back to the communication theme. Two-way communication and frequent communication, and knowing why things are being done, or knowing that the manager doesn't know why it's being done either, but being with them and they're trying to cope with it. And a lot of the communication, not all of it, but a lot of it emanated from those medical officer of health missives that often came on a Friday afternoon, making it sometimes very difficult for homes to cope. Next slide. Safe and supportive options for sharing and discussing experiences with people they trust. Deliberate conversations, not just random, like not just putting people together and letting them happen. Some of that's important, but focused, for example, around the reflective rooms where they talked about grief. Peer-to-peer support, just-in-time education, huddles, webinars, and courses, just short courses, super short courses, to not only prepare people to respond to the pandemic, but to learn about how to compassionately care for themselves and others. Some of the things that we're seeing in the literature, and there's really not much right now. I think we only located 4 studies that have looked at addressing the mental health impacts on care staff and long-term care. It's a bit of a hot mess in the literature right now. A lot of things that were done and are reported as brief reports were just kind of made up and done as you would in the middle of a pandemic. And there's a report. There's all kinds of problems with those little reports and those little efforts that were made. So we're just starting to see people be more systematic about saying, all right, does mindfulness really help? does do huddles. Well, we're pretty sure huddles help because they seem to help for almost everything. They came out of the quality world, but they've been used in all kinds of areas. Is compassionate care an effective strategy? Is what types of breathing strategies and how often do you have to get people to breathe, and with what frequency and dosage? What kind of EAP programs have been helpful, and what is, when they're not helpful, what is it about them that isn't? So the research community isn't used to responding under pandemic conditions. It's doing its best, but I think over the next 24 months, we're going to begin to see a lot of things materialize that may not be radical or new, but may help us understand which things are not only promising, but have the most teeth. Most of what we're seeing now is really early. It's about 25% of it's out of China, which you'd expect because they were early in the pandemic. And the next most common country for producing these things is Canada. So that's good. COVID created different conditions. So much of what's out there around how people responded to SARS and other disasters and events, tragic events and major disruptions, it's relative and it's important to our understanding. It gives us, points us in directions with COVID, but COVID's got some different conditions about it. And one of them is the duration, like it just won't end. And the ups and the downs with, oh, this wave is over and maybe we can stabilize. Oh Lord, here's another one, here's another variant. So based on what we're seeing, that looks like it's one of the features of COVID that's making it particularly hard on people as they just kind of have to hunker down and get through it. And like all of us, wonder when it might ever change. So those are, I think that's my last observation slide. Let's go to the next one. Oh, I had two more. There you go. We need coordinated support for the sector. That's absolutely clear. And as I just went on and on about, identification of the most promising practices so that people are spending limited resources where they're going to get the biggest bang for their buck. And I've talked about how limited the research is at this point in time. Next slide. Thank you very much. I've really skipped over the top, but I'm happy to answer any questions you have. And really, there's a reasonably coherent report on HEC's website that hopefully will direct you to the people you might want to talk to more about for some of the specific things. All right, thank you.
Thank you. Sorry, I'm having trouble navigating to my mute button. So first off, thank you so much for walking through, although a brief summary of your report. I think that the information that was shared is relevant. And I hope it resonates with the people on the call today. And I also just want to thank you for acknowledging how hard it's been over the past 18 months and plus now for this sector in particular. So thank you for that. The first is a comment, just going back a few slides to slide 15, where you spoke about psychological safety and that it's such a good point, and echoing your insights on the importance of psychological safety, different structures of reporting and assistance to positively expand on this work. So just a comment. And lots of thanks in the chat. So I will start with the first question though, and it's in the beginning, you briefly described the scope study with which Trek has done. Can you please describe how this supports the resilience of healthcare aides in the system?
We started that study because we had years of burnout data for all levels of staff, and as not surprisingly for all levels of staff, especially the front line, they're really worrisome levels of burnout before the pandemic happened. But there's also this other really strange scale in the burnout measure that shows professional, it's not strange. What's strange about it is the results. They show these really high levels of professional efficacy, which is just how meaningful you find your work. How much do you think what you do makes a difference, is important and necessary? And everybody in long-term care scores pretty highly on that, but the PSWs and care aides, their numbers are just off the scale. So we scratched our heads, and it's a long turny path, but it led us to this little scope study that was a little in the beginning. It got bigger later to see if we could tap into that. And whether we tapped into that thing, what we did tap into was this experience of when you empower care aides and PSWs, all kinds of literally magical things can happen. They don't always, it requires some guidance and support. So I think the mechanism by which anything that you're doing, we happen to be doing a quality improvement thing where care aides led unit-based quality improvement initiatives, and that's a lot easier to say than do. But there are other ways, there's dozens of ways when you empower them and let them have their voice and bring what they know forward and help them a little bit with language, because professionals like to talk in all kinds of language that's sometimes exclusive. They get a sense of, like, it's the only time in my career, my rather long career now, that I've walked into a room when we would have our learning events, our learning congresses, and you could feel and see what we call the effect size, the effect of the strategy on them, from everything, including posture, literally, through to engagement and excitement, and then all these creative things that would come out. And when you've got that kind of a feeling, we all know it. And I think that's one of the things that right now managers are struggling with. When you feel like that, it makes you more resilient. It helps to buffer all these hard things that are happening. So I think the key is empowerment in scope and in other studies and in other projects, and not even studies, just things that people are doing. And it's something that maybe we haven't always done as much of in long-term care, as for all kinds of reasons that we will be able to do more of now that we see the power of it.
Great. And the next question is it time to put top-down leadership to rest and move to compassionate and inclusive leadership in long-term care and healthcare in general?
Well, I would say yes would be the short answer to that. I really think that really rigid hierarchical top-down structures, I think we've got pretty good evidence that they're not working. I think it's not an either or. I think it's a combination. We know quality happens that way. You have to work from the top and the bottom. And if you don't do either, you don't have success. Like, somebody has to be in charge of various things. But I think we have lots of room to bring in much more leadership from the bottom up. At the unit levels, I mean, we all know that units are where quality is made. Quality people talk about them like clinical microsystems, which isn't a very friendly word, but that's where the staff interface with the patients or residents. It's the coal face. That is such a critical place. And if the people who are interfacing and touching residents don't have a say and aren't part somehow of distributed leadership, I think we're seeing in the pandemic that can be really problematic. And that's in part, I think, part of what's going on when the managers were able to be on the floor and huddle and meet with care aides and listen to them and take some of their ideas forward. So I think, yes, I think it's just kind of punching down from the top all by itself isn't good enough anymore. Maybe it never was, but now it's not, doesn't seem to be working very well.
The next is just a comment around terrific presentation, and stating that we have our work as researchers and leaders cut out for us, but you're providing the direction in which we need to go. So thank you for that. The next question is curious if there is any data on the physician experience in long-term care and what practices may be promising in supporting them.
We didn't hear anything in the interviews we did. We didn't specifically ask, and I haven't seen much at all, if anything, in the long-term care literature about physicians. There's quite a bit going on in the hospital setting, and one of the two trials that's going on in Canada right now that I'm aware of is looking at supporting physicians. I mean, clearly they need support, but physician practice played out differently in long-term care than it did in emergency or ICU. And so in some cases, there were homes where it was all virtual, if even virtual happened in the initial stages. And there are some places in the country that don't have a lot of physical contact with physicians. There are other places where, and I think this is probably a robust practice, where they've really used the nurse practitioner model really effectively. So no, my short answer is no. We didn't hear much, but neither have I read much in the long-term care sector. I think in the hospital sector, and especially from ER and in particular ICU docs, we're going to see a lot come out.
Thank you for that. The next question is, given your experience and expertise, how important do you believe it is for improving communication between long-term care residents and their care providers by improving their sensory health, for example, hearing care and vision care, in order to reduce care burden? Did sensory health of the residents come up at all as a stressor for staff?
It didn't come up in these interviews. It certainly came up in the other interviews I referenced that we did earlier this year. And it came up in 2020 when we did the Restoring Trust report for the Royal Society on COVID-19 and the future of long-term care. Old people have sensory loss, and old people with dementia have both sensory loss and processing ability loss. And it's tough at the best of times. And then you isolate them, and then you dress everybody up like in hazmat, like apparel. And it's horrible for them. I mean, I cannot imagine how frightening and confusing and anxiety provoking it was. So absolutely. And the staff, the care aides knew this, and everybody else who's on the front lines knew it too, and talked about it in these other interviews. It's a major issue at the best of times, and it was magnified at least 1 or 2 orders of magnitude during COVID. It was a huge issue for older adults with dementia, which is most of the population in long-term care. As many as 80% have some degree of cognitive impairment. The diagnosis runs around 65% with dementia, but we know that diagnoses are sometimes underreported. So it's a big issue, and I could talk for a half an hour on just what the devil are we going to do, because it's one of the areas that's like a wicked problem in nursing homes. How do you get services to people? A lot of these services are private. They cost money. Not everybody can afford it. How do you assess people? How do you not lose the glasses, the teeth, and the hearing aids? I mean, it's a big issue in nursing homes, and you can't walk into a home and, well, maybe you could if you had a home where it was like it usually is in a home where it was perfect, and maybe it would feel different. But normally it's not it's one of those hidden things that isn't very hidden for the residents and families, but like it doesn't show up on the inner eye data, and it doesn't show up on safety things generally and whatnot. So no easy answer, but I wish all the occupational therapy and other rehabilitative therapists in the country would go on some kind of a crusade to help with sensory losses, the speech people and the OTs and the audiology people. And it's such a big area.
And we see many of our teams working on that space as well. So agree that it's a priority. Thank you, Dr. Esterbrook. A very thought-provoking presentation, lots to reflect on. I look forward to reading your report. I am wondering why you think the existing mental health support in the workplace standard is not applied more. We are right now investing so much effort into revising HSO's long-term care standards and developing the first CSA standard. What could we learn from the application of the earlier standard, of that one in particular?
If by the usual mental health support, I think the person might be referring to employee assistance programs.
Or the mental health standards as well that you had referenced that are being applied across Ontario.
Oh, what can we learn from them? Sorry, I'll get you to repeat the question. I have my head in another space.
Sure, I'll repeat it if I can pull it up. Wondering why you think the existing mental health support and the workplace standard is not applied more. So I'm assuming that's a reference to those standards that are being spread across Ontario. Right now, we are investing so much effort into revising HSO's long-term care standard and developing the first CSA standard. So what could we learn from the application of this earlier standard? I guess as we look towards implementing this HSO and
Yeah.
CSA standard.
Well, it's a loaded question. I think the simple answer is that we haven't prioritized adherence to the standards. We haven't valued it. Another simple but terribly fraught issue is it doesn't matter how wonderful, terrific, important, and robust the standards are if they're not implemented. When I know that this is something that the people working on the national HSO standards are struggling with, at least internally, is it's one thing to have standards, but there are many other phases around implementation. Are there resources to implement them? Is there a political and administrative and policy will? Do they make sense? Do they resonate with the front line? Can the care managers, like, how do they look at them? Is this just, oh God, this is another thing that I have to do? Because this is a really regulated industry. So it's not that there's anything wrong. I think all the standards that are being revised and coming out now are going to be much, much improved and enriched. And I don't think there's anything necessarily wrong with past standards. I think in lots of cases they were a bit meager. They just weren't filled out much, or there weren't many in some content areas. But I don't think sometimes the why has to do with them not being realistic. But I think most of what we're seeing, or I think we're seeing coming out now, are going to be appropriate standards, but that doesn't mean there are appropriate resources. Like mental health is a hot mess in Canada anyway. Like just a normal, regular working person has difficulty accessing mental health services. If you have a child, that's 10 times or 100 times worse. So mental health services for workers in long-term care hasn't been prioritized. But the worry I have, and many people have, is that, I mean, everybody's worried about, some places call it the big resignation. People are worried that the staff at all levels are so stressed and so affected that as things settle, there's going to be an exodus. I don't know if that will happen or not, but I do know that this kind of stress, it's traumatic stress, has a physical impact on the brain and body, and it results in long-term effects that do not go away when the pandemic or the event's over. So we have to do better, but how we're going to do better is a complex question that's going to, I mean, I think at the end of the day, Jane and Joe Canadian need to get out and march with their feet to the polls, but that's not a clear pathway to change. I mean, it's a big one if people and seniors, I've been told that most governments, although they might not say it, tremble a bit at the thought of a block seniors vote. It's a powerful vote. It's the biggest voting block in the country. So people say that to me, and I think, well, how is that going to help? How are we going to get everybody to vote? And even if they vote, then things won't necessarily change. But it's one dimension. And then I think we need earnest effort on the part of the different bodies that are involved in getting something from a standard that's a bit ideal down to, how do I turn that in my home? Like, what am I supposed to do with that? I haven't, I can't, when I was a student nurse 1,000 years ago, I was taught on Maslow's model, and the most impactful lecture I ever had was, I asked some question that probably sounded really not that swift to the instructor, and she looked at me in a very sobering way and said, well, Carol, you can't give psychological care to a corpse. And I thought, oh, that's right. I have to get my priorities right. So I think, I mean, that's an overstatement. Try not to repeat that, quote me on that. But what I'm trying to say is we have to get our priorities a bit sort of sorted out. And it's hard to know what they are right now. I think that the mental and emotional health of the workforce is quite a high priority, because if we lose a big swath of people, for example, at the manager level, the long-term sector is going to be in a lot of difficulty. And I don't think across the country, we broadly and adequately prepare our managers. Most of them are nurses. And historically, what we've done with nurses, oh, she's a pretty good clinician, let's make her a manager. 2 weeks later, you're spinning and dizzy because you're doing this management thing. And it's a tough job. It's a tough job in any sector, but in this sector, it's especially difficult. So I'm conscious that even though I'm on that National Standards Committee, we mustn't be seen to be asking people to do the impossible. And so we have some work to do with other bodies in the country to try and figure out how these might be enabling standards and not fraught. Sorry, that was long-winded, but you hit a nerve.
Good reflections, Carol. The next comment is just really thank you for engaging the frontline in your work and focusing on empowering caregivers, as it's really important. And also just for highlighting the importance of huddles, which have been used in some of the appropriate antipsychotics works that originated in Winnipeg with Cynthia Sinclair back in 2012. And that also that they saw a lot of increased cohesiveness as well as a result. The next question is around peer support. So given that peer support was seen as a chosen way for care aides to cope with grief and work stress, could wobble rooms that were put into acute settings be helpful in long-term care?
Well, they might, but I don't know what a wobble room is. So I have no idea what a wobble room is.
I'm not sure either. So maybe the person who made that comment could add some extra detail in the chat box, and hopefully we'll have time to come back. The next question is around servant leadership. So servant leadership pays huge dividends, especially with the new workforce. Leaders create vision and encourage pathways to get there. It was so true during the past 20 plus months. I guess so just a comment if you have any reflections on that.
No, not, I don't think anything beyond what I've already said. I think it's consistent with what we're hearing.
Agree. I'm going to stop navigating away from my mute button because I'm having trouble getting back to it. In some of my research, including personal support workers as part of the interprofessional team was perceived as valuable to both the personal support workers themselves and other team members. So there's lots of appreciation for personal support worker contributions, noting their unique perspectives with respect to clients. And I think that you also feel that way. And a lot of research that you do is focused on personal support workers as well. Was there any indication that peer support might be harmful as offloading to peers, other staff might serve as an added burden?
We didn't hear anything in the interviews we did for this report. People who were bringing it up brought it up as positive, and we've seen it be positive in some of our work, but it's an important point. I think people need some tools and some, I don't want to say safety, but I think, or monitoring, those aren't quite the right words, but the environment in which that's encouraged, I think is important. I think that it's not bad to think about some facilitation of those peer-to-peer support groups, because you've all seen them, or many of us have seen them turn into rather negative. Remember, this is a group of people who are, number one, they're extraordinarily resilient, but they're also right now, even if people yet don't quite feel the impact of it, they're quite traumatized. And so I'm a big fan of tools and a little bit of facilitation, not too much. And the question is, who does that facilitation? It has to be somebody they trust. It doesn't have to be like watching them all the time, but some kind of checking in. I think the comment's important, that we need to be mindful that it's not going to happen, I don't think, a lot, but when you get one of those offloading, it getting worse little cycles going, it needs to be interrupted. And I'm talking about something that's fairly sophisticated to do in an environment that is still putting out fires. So I know it's easy for me to talk. I don't know, I don't think Don McLeod, who works with me, is on the line, but if he is, he might be able to pop in around how you might facilitate that. He's done a huge amount of facilitation for us. And if he's not, maybe we can follow up in some way, because it's an important question.
For sure. And so Catherine Flo just added the back to the wobble room question is that it's a quiet room that staff can visit when they are overwhelmed and need peace and quiet.
Oh.
It was started in the UK during COVID. So when staff are having a wobble and need a moment to themselves.
A great term. Absolutely. I think they're really important because sometimes one of the hardest things to find in a long-term care room is just a few minutes where it's quiet and you're alone, and it's hard. Some of these buildings aren't built with any of this stuff in mind. So I think they're an important practice, and they would be consistent with the idea of reflection rooms. Some people have little chapels that people go to, but not every place has a little chapel room or a quiet room. So absolutely, I think, and encouraging people visibly to take a quick time out and just gather their thoughts and reground themselves, pull themselves together if they're feeling really, as she says, wobbly. That's a nice term. I like that. How many of us haven't felt wobbly in the past 20 months? But in this sector, I think they live under a constant kind of wobble, especially when those waves are high. And now what we're hearing is that you might feel like it's going to settle, because I think everybody's full of hope that it'll settle. And then we get a new variant, and this one's called like a Decepticon name. Like, who thought that up? But like when these new things happen, it's like a kick to that kind of hope that it's going to get back to normal. And we hear a bit about people finding that really challenging. Oh, there's a fourth wave. Oh, there's a new variant. Oh, we need another booster. I think it's tough on the population, but it's especially tough on people in long-term care.
Agree. So I'm going to try to combine the last two questions into one so that we have time to get to all of them. So coming back to the sensory loss, in LTC residents, did you hear that it played a role in potentially the communication breakdown and social isolation experiences and subsequent mental health challenges? And if yes, what are some training opportunities for care aides and staff? And has COVID changed this? It's kind of a multi-pronged question. And then where, I guess, do you think art therapy, music therapy, and those types of non-pharmacological interventions fit into the picture? And how do we get them back into the homes? Because we know many programs stopped during the pandemic.
Those are big questions. I think just on a superficial level with sensory things, I think in some cases we may have learned, I know in some jurisdictions, not necessarily long-term care, there are ways to use PPE that aren't as hazmat suit-like. So I think there's some physical materials that we can use, like transparent masks and things like that. I don't think we solve the hearing issues because you're behind a mask and you're muffled. So I think we have to work on that. They absolutely played a role. I mean, the isolation. There was a report in October of 2020 in the Washington Post, and they reported that in a 6-month period in 2020, there had been 13,000 excess deaths in the United States because of COVID conditions. The death certificate said dementia, but they estimated that 13,000 of those people with dementia on their death certificates had died because of the isolating conditions of COVID. That was quite a well-done study using CDC data. So I think we have to figure it out fundamentally. And then during COVID, like, I don't think we ever thought, what will we do if everybody has to dress up in a hazmat-like suit? And people are in isolation and they're in bed, so they're maybe never going to walk again. And like we restrained people in their rooms and didn't let them out. That's restraint. That's physical restraint. And that's so anathema to what we think is right in most long-term care jurisdictions. And absolutely, like I'm a big fan of non-pharmacological stuff, because we all know that we medicate people really heavily in long-term care. And even if it isn't with antipsychotics, they're on a lot of medications. And there's so much stuff that we can do, but the question is, how do we, well, first of all, not everybody's got the resources to do everything. So pets and music and textures and art and all those sorts of things that bring meaning and a little bit of joy to life. We need to have those in normal times, but how do we get them back? I don't know. It's going to take some effort because we have to stabilize staffing. That's so basic. We have to stabilize staffing. And then we have to understand, and everybody on this call does, but the world doesn't understand. These are homes. These are not chronic hospitals. They're not supposed to be chronic hospitals. They're supposed to be homes. They're where you go to live the last stage of your life. And you deserve, as an older Canadian, to live it with some peace and moments of joy. And that might sound motherhood and apple pie, but that's what everybody wants to do. And so, but you can't do that if you haven't got enough staff to cover basic needs. And if your model is quite medicalized, which our model still is, it's quite task focused, because that's how regulations and quality things sometimes tend to work. So I don't have an answer for how we get them back. I think we need to, and I think we need to prioritize putting more things back that are home-like, and rethink how we think about risk. And I mean, I would be a big fan of everybody on the call and the 14,000 contacts you have participating when the next round of when the draft standards come out for public input, and there'll be a round of town halls and engagement, not so much just for the people writing the standards, but to send a real clear message that people care. The fact that 16,000 people answered the survey about standards, what should be in the standards, that's a big deal in this country. And you can say to politicians, 16,000 people took time to do a survey. I think people care about this issue. So sorry, I don't have good, clear answers, but I don't think there are easy answers. I think there are a lot of creative people out there, and let's engage some of the young creative people and build capacity in long-term care while we're doing this problem solving, because they figure out stuff faster anyway.
Thank you so much, Dr. Ester Brooks, for this great hour that we spent together. I'm sure everyone on the call looks forward to reading your report, and thank you to everyone on the call today for such an engaging conversation. I know we may have missed one question or two, so we will commit to following up and responding to all of your questions. And then speaking of the National Long-Term Care Standards, our next webinar will be the virtual learning series on January 17th, where Dr. Samir Sinha will actually provide an update on where they are with the National Long-Term Care Standards. And I believe they are going out for consultation. And Carol, you would probably know that for sure. Excellent. So thank you so much to everyone, and please complete our poll for today, and wishing everyone a great afternoon.